So let's go about the head neck. After anatomy of the head neck, what are the disorders of central nervous system? From this book, MRCS, cerebral stroke. You can see posterior circulation infarcts. As you know, there is circle of Willis is there. Posterior circulation infarct, the posterior arteries, vertebrobasilar arteries. Two vertebral arteries, they join together to form a basilar artery. Whenever this basilar artery and vertebral arteries, they are supplying to the posterior part of brain. So presence with feature of brainstem damage. This is basically supplying to brainstem. It's very important. So person is suffering from ataxia, disorders of gaze and vision, occipital cortex as well as cerebellum. So posterior circulation infarcts, POCI, it is around 25% of the infarcts there. Now lacunar infarcts means this involves perforating arteries around the internal capsule. Internal capsule is an important part in the brain through which all the fibers they decussate. So thalamus and internal capsule basal ganglion. Again, manifestation is isolated hemiparesis, hemisensory loss or hemiparesis limb ataxia. Ataxia is important as basal ganglia is involved. Lateral medullary syndrome. This is also called as Wallenberg syndrome. Posterior, this is PICA, posterior inferior cerebral artery. PICA. Questions are coming on this. Posterior inferior cerebellar arteries. So it is called as Wallenberg syndrome, lateral medullary syndrome, ipsilateral, same side ataxia, nystagmus, dysphagia, same side, and contralateral sensory loss. So this is Wallenberg syndrome, involvement of PICA. Third nerve palsy, as we have seen, oculomotor, olfactory, optic, oculomotor. Third nerves, most of the eye muscles are supplied by third nerve. Only SO4 and LR6 are left, and remaining all muscles are supplied by third nerve. So eye is deviated down and out. Why? Superior oblique is trying to pull it down and lateral rectus is trying to pull it out. So these two muscles are, lateral rectus is pulling out, superior rectus down. So whenever palsy of third nerve is there, two muscles are action, SO4, LR6. So they are causing down and out. Ptosis is there, pivotal papillary muscle is supplied by third nerve, so ptosis, pupils are dilated. So unopposed, this is just like a sympathetic mydriasis, dilation of pupil. When does it happen? Diabetes mellitus, vasculitis, temporal arteritis, systemic lupus, posterior communicating artery. Painful third nerve palsy. Whenever this third nerve is passing to cavernous sinus, when the thrombus is there, that's why painful. All nasopharyngeal carcinomas. Note that if the patient presents with symptoms of acute stroke within 3 hours, if a patient is coming within 3 hours, you have to go immediately. These are acute strokes. Immediately aspirin, he should be urgently referred to medical team for thromboprophylaxis because to prevent further damage to the brain. So these are about the cerebral strokes. Established strokes, not the transient attacks, it is established stroke. So within 3 hours patient is presenting, you have to go for thrombolysis. So what are the brain tumors? Most commonly, children, they are having histiocytoma. Metastasis is most commonly in adults, metastasis seen. Choroid plexus, dermoid tumor, ependymoma, most common site is fourth ventricle. So there is usually hydrocephalus in the fourth ventricle, ependymoma. Frontal gliomas, neuroglial cells, meningioma. These arise from the arachnoid capsules at the dural reflection, tentorium cerebelli and all that, meningioma. 90% are benign. Meningiomas, 90% of meningioma are benign. This is not malignant. Name is meningioma, but it is benign. It is commonly seen because of radiation exposure, genetic syndrome like neurofibromatosis 2, type 2, NF type 2 is one of the this syndrome is there. MRI with gadolinium Best imaging modality, CT scan show calcifications. Radiation is the treatment or surgery can be required. This is again question about glioblastoma multiforme, most common and aggressive primary tumor of the adults. Most common is origin is arising from the glial cells, supporting cells, astrocytes classified as grade 4 astrocytoma. It is highly malignant, rapidly growing, invades surrounding brain tissue. Etiology, gene mutation, TP53, EGFR amplification, IDA mutation. So this is genetics. Exposure to radiation to the head rarely associated with genetic syndromes like Li-Fraumeni or Tourette syndrome. MRI with contrast shows a ring enhancing lesion. This is the question, ring enhancing glioblastoma or ring enhancing lesion whenever you do MRI, and central necrosis is the hallmark finding. Ring enhancing plus central necrosis. This is hallmark. Histopathology, gold standard highly cellular tumor with areas of necrosis surrounded by palisading tumor cells and microvascular proliferation. Radiotherapy is the treatment. Clinical picture of brain tumor, any tumor which is there inside the brain that will cause raised intracranial pressure. ICP is always raised, so person is getting headache, nausea, amyloidoma, focal neurological deficits. Differential diagnosis of brain tumor, abscess can be there, intracranial manifestation, plus fever, ring enhancing lesion can be seen in abscess also. Treatment is surgical excision. Brain metastasis should be treated medically by high dose corticosteroids. You have to just. So, coming to the pituitary disorders, apoplexy, sudden hemorrhage into the pituitary gland. Hemorrhage often occurs in non-functioning pituitary adenomas. Sudden onset of exuding headache, diplopia due to pressure on oculomotor nerves, hypopituitarism. All pituitary hormones are depressed and decreased. So all pituitary hormone deficiencies can occur. Sudden onset of ACTH, adrenocorticotropic hormone, cortisol deficiency is most serious because it causes life-threatening hypotension. So investigation, MRI, hemorrhage, hormonal deficiency may be depicted in hormonal assay. Treatment is high dose of steroids are required. Administration of dopamine agonist to reduce adenoma size. Surgical decompression of pituitary is performed in the cases with severe problem. What about this Sheehan syndrome? Where does it occur? This is severe postpartum hemorrhage of hypovolemic shock causing pituitary infarction. Suddenly, pituitary gland has got low supply of the blood. That's why leading to Sheehan syndrome. Remember, it is from the Sheehan, means blood lost in the postpartum. History of severe postpartum hemorrhage, hypopituitarian failure to lactate. So there is prolactin deficiency and person cannot have milk production. Amenorrhea, gonadotrophin deficiency, hypothyroidism, TSH deficiency, fatigue, hyponatremia, ACTH, cortisol deficiency. All the hormones of pituitary gland are depressed. So postpartum patient may have such symptoms. So investigation, MRI reveals the hemorrhage. Hormone deficiency may be detected in hormonal assay. Hormonal replacement therapy, you have to supplement from outside corticosteroids, glucosteroids, adrenal insufficiency, levothyroxine for hypothyroidism, growth hormone to be. Another important one, Hepel-Lindau syndrome. VHL gene, there is problem with the GL, chromosome 3. VHL 3 means there are 3. So what is the, you get pheochromocytoma, cerebellar hemangiomas, retinal hemorrhages, endosac tumor, endolymphatic sac tumor, extrarenal cyst, ependymal pancreatic hepatic renal cyst. Coming to the ear disorders, most of the questions are coming for this. Acute otitis externa, external ear infection, malignant otitis externa, acute and malignant means cause is boil, any boil in the auditory meatus, clinical picture, severe pain in on the moving of ear prick, may be history of ear prick, topical antibiotics given, operative debridement may be needed in severe cases. This is about acute otitis externa. Malignant means long-standing infection is because of pseudomonas and immunocompromised patients. Start external auditory meatus, progress to temporal osteomyelitis, severe earache, otalgia is there, temporal headache is there, purulent edema, otorrhea, pus discharge is there, dysphagia, hoarseness, and facial nerve dysfunction. Anti-pseudomal, topical hyperbaric oxygen is sometimes required. This preauricular sinus, what is this? The questions are again on this preauricular sinus. It is from the external ear, commonly condition in the epithelial defect around the external ear. Deeper sinuses may be blocked and attacks of infection. That was external. Now coming to otitis media, again it is acute and chronic. What is acute? Most of the time causes of acute is viral herpes zoster, middle ear effusions, secondary eustachian tube dysfunction, most common in children and rare in adults. Acute suppurative ASOM and CSOM, chronic suppurative otitis media. ASOM common in children, pain, fever, symptoms. Elsewhere, vomiting there, discharge from the tympanic membrane is ruptured. Most of the time, paracetamol, painkillers are required, steroids are required, non-steroidal anti-inflammatory drugs most won't be. Antibiotics are not required because maybe viral. So antibiotic needed if there is unwell, high fever, bilateral infection, both otorrhea secondary to perforated tympanic membrane. Amoxicillin or erythromycin or clarithromycin has to be given. Chronic suppurative otitis media (CSM) can be with cholesteatoma, where there is perforation of pars flaccida. Pars flaccida is a upper part smaller and pars tensa is a larger part. When without cholesteatoma, when there is pars tensa, there is no cholesteatoma. Cholesteatoma is there when there is flaccida, perforation of the flaccida. Now, clinical picture: if patient is having cholesteatoma, there will be loss of hearing with foul smelling. This is there, foul smelling discharge. You click, you have to answer cholesteatoma. Without cholesteatoma, complaint of intermittent discharge, non-offensive. Pars tensa perforation may be managed non-operatively by meringoplasty. Tensa, this is tympanic membrane, and this part is the pars flaccida, and this is tensa, meringoplastic membrane. Pars flaccida perforation radical mastectomy. Now, cholesteatoma is destruction, expansion of the squamous epithelium in the middle ear, characterized by foul smelling discharge of pars flaccida perforation. Schwannoma are what are the acoustic neuromas or vestibular schwannomas? Acoustic neuromas are encapsulated tumors arising from benign neoplastic Schwann cells. They are most common tumors of peripheral nerves and generally do not transfer into malignancy. Vestibular schwannomas account 80 to 89% cerebropontine angle vestibulocochlear tumors in the adults and discussed separately. Progressive unilateral sensory loss and neuronal hearing loss may be bilateral neurofibroma type 2. Facial nerve vestibulocochlear may be involved. 2 nerves, 8th, 7th and 8th nerve. Ultrasound may mass revert. Magnetic resonating imaging, best modality for diagnosis. Computerized tomography can help in identify the mass and its relationship to the surrounding tissue. Small asymptomatic tumors follow up with the serial imaging. Initial follow-up MRI at 3 to 6 months to ensure stability. Large or symptomatic tumors, surgical resection is required. Sarcoidosis, bilateral facial nerve. This is again question. Bilateral facial nerve palsy, corticosteroids are helpful. That is sarcoidosis. Bilateral neurofibromatosis type 1. Complex multisystem human disorder characterized by different sizes of the legs, learning difficulties, café spots, optic glamours, schwannomas, more than 6 centimeter. So what about this hearing loss? There are two types of hearing loss, sensorineural and conductive. Conductive means there are the bones which conduct this. Incus, malleus, stapes, they are conducting the wave from the tympanic membrane to the neural pathway from the inner nerves. So whenever bony involvement is that is called as conductive hearing loss. Problem is transferring sound along the ear. And sensorineural is problem is the inner structures, cochlea or the hair cells or nerve pathways. These are the hair cells or nerve pathways. So test to detect type of hearing loss. Which type of loss is there, whether it is conductive or the sensorineural loss. There are two tests. One is Rennie's test. What you do? Tuning fork is kept on mastoid till the sound stops. First of all, you are vibrating the fork and it is kept on the mastoid. Here is you can see. First of all, you keep it in front of the ear. If you are keeping it on the mastoid, then place next to the ear. Both ears are measured. Finding normal air conduction is twice the Bose conduction. So person is having, even if the sound has stopped from the bone, when you keep it on the mastoid process, and then it stops and you ask the person whether he is hearing. If yes, so it means that is positive. So how to interpret is bone conduction, if it is more than air conduction, that is negative, so it is abnormal. Now air conduction is more than bone conduction, so first part is measuring conductive deafness, means once it is stopped and a person is unable to hear, it means from the bone he is able to hearing, from the air he cannot, that is negative, so there is conductive deafness. While if nerve pathways are deaf, air conduction is more than bone conduction. So here, but it should not be twice. Just to simplify, more the bone conduction, it will be conductive hearing loss. More the air conduction, it will be sensorineural hearing loss. Now Weber's test, tuning fork is placed in the center of the head. This is tuning fork is placed here, center of the head. Normally heard conductive deafness, wherever deafness, conductive deafness, that heard in the affected ear, one ear. Sensorineural, normal ear, he is hearing the sound. Normal sounds heard equal on both ears. Normal person should have equal, but if he is having sensorineural deafness, heard in the normal ear. If he is a affected ear. Disease of the nose, tumors of the nose, benign papillomas may be incidental finding. Excision under general anesthesia is required when papilloma. Transitional cell papilloma extensive produce obstructive symptoms, erosion of local surface and undergo malignant transmission. Careful complete excision required total maxillectomy. Nasal polyps, benign lesions of ethmoidal sinus mucosa, clinical picture asthma, cystic fibrosis, and sensitivity to aspirin. Santastride, what is this? Cystic fibrosis, asthma, and sensitive to aspirin. Watery rhinorrhea, infection, and anosmia. Repeated infection, watery rhinorrhea, and unable to smell. So that is because of this entire treatment is either with steroids or surgical resection of the polyp. Malignant tumors pathology arise the nose and paranasal sinuses. Adenocystic carcinoma is the malignancy of this. Squamous cell carcinoma, adenocarcinoma linked to the exposure to hardwood or more than 10-year exposure. So wood workers, they are most of the time exposed to this. 50% arise from lateral nasal wall. Signs of malignancy on clinical examination: loose tooth, cranial nerve palsy, lymphadenopathy. Coming to infection of the sinuses, maxillary sinus, frontoethmoidal sinus. So here, if it is frontoethmoidal sinus, his person is getting frontal headache, nasal discharge obstruction, altered sense of smell. Ocular symptoms may occur via emissary veins to CNS. Manage with antibiotics. Severe cases require surgical drainage. Maxillary sinus, headache is there, nasal discharge, altered sensation of smell, toothache. Again, treatment is lavage, relieve symptoms. Antimicrobial therapy may be required longer period. Antrostomy, the drainage has to be done, as the reason is two factors make maxillary sinus more liable for infection. Position of the ostia is at the roof upper side, which makes drainage difficult. Relation of maxillary sinus to the posterior teeth make it more liable for infection. This is the very commonly asked question about epistaxis. Arterial supply of the nose. Arterial supply has got Little's area or called Kesselbach's area is a source of bleeding in 90% of the cases. Little's area, septal branch of the facial artery. This is the question. Sphenopalatine branch of maxillary artery. Answer is always sphenopalatine branch. Upper ethmoidal arteries of ophthalmic arteries. Lower is sphenopalatine, greater palatine branches. Greater palatine, sphenopalatine, maxillary artery. They are forming the Little's area. 75% of the cases is primary. Secondary may be due to anticoagulant, trauma, or coagulation management. Research the patient should sit up and pinch the nose firmly. Simple anterior epistaxis may be managed by silver nitrate cautery. Failed packs may be inserted. Posterior packing of tamponade may be passing balloon tamponade device. A vascular radiology suit is available. Direct ligation of nasal artery, sphenopalatine ligation. sphenopalatine artery ligation. What is Ludwig's angina? Serious infection of the floor of the mouth. Swelling of the submandibular gland or submandibular area neck. Difficulty in swallowing, dysphagia, pain and tenderness at the neck, under the tongue, fever, chills. Intubation is required because sometimes it can compress the airway. Antibiotics, empirical treatment, broad spectrum antibiotic, incision drainage to drain this is the acute treatment. Tonsillitis, infections of the tonsil, most common in the children, sore throat, odynophagia, fever, lymphadenopathy. Quinsy is peritonsillar abscess, swelling lateral to the tonsil, trismus, difficulty in opening the mouth, hot potato voice, muffled voice, deviated uvula, IV antibiotic aspiration, incision drainage. Parapharyngeal abscess, patient has a neck spasm. Retropharyngeal abscess, it is secondary again because of Lameri syndrome, infectious thrombophlebitis of internal jugular vein. Tonsillectomy bleeding, primary within 24 hours. A person gets called after surgery within 24 hours. Primary, secondary is more than 24 hours. Primary bleeding, return to the patient at operation theatre. And analgesia, non-steroidal inflammatory, antibiotic, penicillin, clarithromycin for people who are symptomatic well or have high risk of complicating. People with fair pain, score 4 or 5, score 3 to 5. So what are the criteria? Fever more than 24 hours during previous 24 hours. 1. Purulent discharge, then attain rapidly within 3 days after onset of symptoms. Severely inflamed, no cough. These are scoring. Indications for hospital admission: severe systemic infection, suppuratory complication, airway compromise. Indication of tonsillectomy: if the person is getting 7 episodes in 1 year, 5 episodes for period in 2 years, and 3 episodes for a period of 3 years. In 1 year, recurrent episodes of more than 7, you go tonsillectomy. 5 episodes per year for 2 years, 3 episodes per year for 3 years. Sleep disorder, breathing. So this was about the neurosurgical disorders.